Hello, future nurses. This is Professor Flourish. So I actually got this end of life care from Professor Morris, this PowerPoint slides, because he used to work in hospice. So he definitely knows a lot about this. If you're curious about going into hospice or you have questions, please let me know. I can get his email address for you and you can talk to him about it just because he knows a lot about that particular field. So the first thing is the do not resuscitate. So do not resuscitate means, so DNR, do not resuscitate, means that chest compressions will not be performed in the case of cardiac arrest. So if your patient goes into cardiac arrest, you do not do CPR. Now, everything else is still available. So that means that if they've got a bacterial infection, I'm still giving them antibiotics. That means that if the patient needs to be walked, I'm still walking them, because there's actually a lot of people who are in good health that may place themselves on DNR list, but they still expect full treatment. CPR may not necessarily always have the best outcomes, because if you think about just CPR in general, when you're doing CPR, you tend to compress the chest, so you can end up breaking bones, and it may prolong something opposed to some patients would rather just pass from the cardiac arrest. So it's ultimately the patient's decision. A DNR, DNI means do not resuscitate, as well as do not intubate. So this means no chest compressions as well as no intubation. Now, some patients may say, I will be a DNI, but I'm okay with being having CPR done. So you have to be kind of careful and look at your order sheet. So all these orders come from their advanced directives. So this advanced directive is a legal form that describes how the patient wishes to be managed in the event of incapacitation. So it's usually written by the patient or written by somebody who knows the patient, and the patient saying, okay, this is what I want to get done. It comes in many forms, and the RN should honor the advanced directive as much as possible, even if the family is pushing for directives violation. So what you can do when you're talking to family is just make sure that you keep on reminding them that this is the patient's decision ultimately. Now with this, if you do not have advanced directive, it does not matter if your patient's terminally ill. If there's no advanced directive, no order for DNR, you will do a full code. You will do everything that a code needs. You will make sure that you are doing that CPR. You're making sure that you're pushing all the medications that you need and ACLS. If there is no advanced directive, if there's no order for DNR. Durable power of attorney is the person who basically makes the health decision for the patient. They're also called the health proxy, health surrogate, or surrogate decision maker. So anything that's healthcare related, while the patient's unable to make decisions for themselves, goes to this durable power of attorney. Now, they do not have the power to make decisions outside healthcare related issues. So the only decisions they can make are with the patient's healthcare. Anything like a living will, anything like finances, anything of that nature is not under their jurisdiction. It's only healthcare. So this research is from the National Hospice and Palliative Care Organization and National Hospice Foundation. About 25% of deaths occur at home. More than 80% of Americans would prefer to die at home. So kind of just thinking about that, where even though most Americans would rather die at home, only 25% of them are actually occurring at home. Hospice care provides support and care for those in the last phases of life-limiting illness, recognizes dying as part of the normal process of living, affirms life and neither hastens nor postpones death, and focuses on quality of life for individuals and their family caregivers. So hospice really does kind of go into this psychosocial aspect and does this holistic kind of what is best for the patient. In hospice care, it can be in a hospital or it can be at home. But the whole goal of it is just kind of helping provide that support in those last phases of the patient. Some of the core aspects of hospice care from the Medicare hospice benefit are patient and family focused. So it's very big on making sure that you're not just looking at patient, but also family. Interdisciplinary team care. So making sure we've got everybody on board. Provides a range of services. So it can be case management, pharmaceuticals, durable medical equipment, supplies, volunteers, and grief support. So it's definitely encompasses a lot. Some of the additional services, and one thing to keep in mind is that not all programs offer these. They're just kind of based on the needs in the community, mission, resources, anything that they've got. So hospices can offer additional resources, including things like a hospice residential care. So that would be a facility for people that are in hospice, inpatient hospice care, palliative care, complementary therapies, caregiver training, and community bereavement services. So part of the patients that are in this hospice team members, the patient's personal physician, hospice physician, so medical director, your nurses, your home health aides, your social workers, clergy or other counselors, speech, physical, occupational, and trained volunteers. So like I said, hospice team has quite an array of different people all coming together. So the work of the hospice team is to develop that plan of care, to manage pain and symptoms, to attend to that emotional, psychosocial, spiritual aspects of dying and caregiving, teaching the family how to provide care, advocating for patient and family, providing bereavement care and counseling. So they develop this kind of care with the family, making sure that they're managing with these signs and symptoms. These are basically the primary services offered by hospice. Now, not all patients and families will want these services, but they do kind of offer these to kind of work with the patient. The whole goal of this hospice care is to work with family, work with patient. So speaking of that role, what is the role of the hospice nurse? It's to keep the patient comfortable. So that is our main role, is to kind of keep that patient comfortable. Educating the family on how to care for the patient. So making sure that they understand what are the signs and symptoms of death. What are things that they can do or should do. Managing emotions of the patient and family as best as possible. So it really does take a certain kind of person to be able to work in hospice, because you have to be able to not only adhere to your patient, but also the family. Keep the patient in the patient and family's preferred environment, so usually at home. So that's something that's very stressed, is hopefully getting them to home. Managing medications, equipment, and supplies that the patient may need. So where is hospice provided? So we talked about this a little bit before. It can basically be delivered across all care settings. So it can be the home, the patient or loved one's home, nursing facility, assisted living facility, hospice resident or unit, correctional setting, homeless shelter, wherever the person is located, you can provide that hospice care. So when it comes to pay, it can be things like Medicare, Medicaid, insurance, HMOs, private pay, and sometimes it can be a combination of all these different things to help pay for these hospice services. So this is the admission criteria. To qualify for hospice care, these are the general requirements. So you need to have a life-limiting illness. Prognosis is 6 months or less if the disease takes normal course. Live in a service area, so they have to actually provide it within that area. Consent to accept services. Forgo other medical interventions for the terminal illness. So those are the admission criteria in order to actually go into hospice care. So what is palliative care? So some think of palliative care as hospice that isn't defined by the 6-month hospice benefit. It's important to understand the subtle differences between palliative and hospice. So Palliative care, treatment that enhances comfort and improves the quality in the individual's life who is facing a serious illness but may not qualify for hospice care. The expected outcome is relief from distressing symptoms, the easing of pain, and or enhancing the quality of life. So when you think about it this way, all hospice care is palliative, but all palliative care isn't hospice and doesn't have to provide the same range of services. Most hospices were designed based on that HMB model. This model kind of limits admissions to hospice to those with 6 months prognosis and that the discontinuation of curative treatments. Palliative care doesn't have those limitations. Palliative care programs don't have to provide the same range of core services, things like bereavement, spiritual, social work, anything like that. So palliative can be given to a variety of more patients than hospice that's a little bit more focused on a certain group. So these are the different kinds of care. You can have curative care, which focus on the cure to an illness and the prolonging of life. Palliative care, which focuses on comfort and quality of life that may be provided with other treatments. Comfort care only means that interventions are aimed at reducing symptoms only, typically for hospice approaching patients who are currently hospitalized, but not actually on hospice care. Hospice care focuses on comfort and quality of life when a cure is not possible with specialized care and services. So these are some of the stages of dying. Oops, sorry. So you'll have loss of functionality is one of those stages. Living in the past, loss of appetite, sleeping all day. You can kind of see these different things going with the patient where they're moving towards more of this dying phase. Active dying. So these are your final stages of dying. That's things like your loss of thirst, difficulty swallowing, sleeping all day, speaking with the deceased, your Jabovsky-Stokes breathing, terminal secretions, limp and cool extremities, and molting. So it's things like that level of consciousness changing. They may not have continence anymore, so urinary incontinence, seeing changes in your vital signs where things aren't the way that they should be. The Jabovsky-Stokes breathing is a period of apnea where the respiratory drive is ignored. Once the respiratory drive kicks in, the patient must hyperventilate to catch up. So it's basically like a followed by a no breathing at all. Usually this can be interpreted as a sign of impending death and relaxation. So your dying patients will have these terminal secretions, so that death rattle. And what that is a collection of fluid in the bronchioles and over the vocal cord, over the vocal cords. It rarely disturbs the patient, but it can be kind of daunting for the family to hear. Now, so with it, you kind of want to reposition or give an anticholinergic medication to kind of alleviate this. Like I said before, this is typically done for the family's sake rather than the patient's. They can give a scopolamine patch or atropine drops usually are given. And that positioning can help a little bit, especially for some of those secretions that are right in the back of the throat. Is reproducible by a healthy person, so it does not indicate that shortness of breath. It's just that they've got all these secretions here. Now, with your terminal secretions, you don't suction your patient because it does not typically work, and it can cause distress to the patient. Some of your medications that are used at the end of life for pain, they'll use opioids, such as sublingual morphine, as the patient does not have to swallow. Corticosteroid steroids for many of the disease processes. So things like your cancers, they'll use corticosteroid steroids. NSAIDs are used sparingly. For dyspnea, you can use liquid morphine because morphine, it's not necessarily given for pain as much as it's given to help alleviate some of that breathing. Low dose supplemental oxygen, mostly just for their comfort. Breathing treatments and corticosteroid steroids if the patient can tolerate them. For nausea, we're giving things like Phenergan, Ondansetron, all these different kinds of medications. So why do we not give IV fluids? You can provide oral care, but we don't usually give IV fluids, isn't going to help them. IV fluids do not cure the prognosis. So at this point, we're at a point that this isn't going to help the patient. They can prolong the active dying phase while the patient experiences increased discomfort. Dying patients will go into renal failure and will experience fluid volume overload, further increasing their discomfort. So remembering all those things with fluid overload, because at this point they're getting ready to pass. So we're just kind of making the problem worse with them. So they can do things like develop ascites, peripheral edema, and crackles. So with the dying patient, it really depends on the person, what you would kind of do for your psychosocial with them. Some people accept death, some people do not accept death. Some of them want their family to go ahead and be okay when they are gone. Typically, they're rarely afraid to die and they're generally relaxed. This all kind of just depends on the patient that you're communicating with. So when you're communicating with the dying, you want the patient to steer the conversation. So open-ended questions. You don't want to just be in there trying to control the conversation. It's like that video with the empathy versus sympathy. You want to allow them to express themselves. Do not use direct orders unless necessary. So kind of living in their world. Do not reorient the patient if they're speaking with the deceased, and do not provide false assurances. So just kind of letting them handle what's going on. Now, when the patient does actually pass away, the first thing you want to do is just document that death. Once that's happened, then we can kind of get into the post-mortem care. So once you've documented the death and everything's gone like that, the priority is providing the family their culturally and religious sensitive care in body preparation. So if the family has something that they want to do, typically we go ahead and let the family do it. Give the family as much time as needed with the body, allow them to participate or control post-mortem care. Because it's like I always tell you guys, we're with our patients for a relatively small amount of time. These family members, that's somebody that they care about. Potentially, it's somebody that they want to do these things for. You want to place the client in a supine position. You remove all tubes and lines unless an autopsy is planned. So for things like if somebody's been in a car wreck and they need an autopsy, then you'll leave the tubes and lines, or if there's some reason. And usually what will happen is when a patient dies, after you've documented the death, they pronounce them dead, you go through a different steps with it, where you talk to TDS, they die in the hospital, and you basically just see whether or not an autopsy is needed. You place an ID tag in 2 places after cleaning. Typically, you want to wait for the step until the patient leaves if possible. So for your patient, there's actually 3 different tags that you'll need for them before you actually put them in the body bag. So one goes on the outside of the body bag, and then you put the other one in 2 different areas, so you've got enough for it. You also want to notify the morgue. And these ID tags are usually in the bag itself. When the body bag comes up, there's usually tags in there, and it kind of gives you an explanation of what you need to do for it. So when you speak with the family, do not assume the patient was well loved. Don't assume that they're going to necessarily miss the patient. You just want to kind of use very vague statements, like, I'm sorry for your loss. Do not use direct orders unless required. So don't tell them they have to do anything, just kind of be there. And sometimes the best thing you can do is just be silent and let them do the talking. So when it comes to grief, mourning, and loss, grief is the emotional feeling related to loss. Mourning is the externalized social expression of grief. When interacting with the mourning, nurses should spend the vast majority of the time listening and basically enacting therapeutic presence. There's several theories that exist about it, but the most famous one is that Kubler-Ross's stages of grief. With it, depending on your patient population, they can have different understandings of death. Like your younger children, once they reach the age of like 5 and above, they see it as more permanent, but younger than that, they may not necessarily. So Kubler-Ross's stages of grief, you just want to be aware that not every patient and family will progress through all stages. And they rarely go through stages in order. Rather, it's a way to understand what people are experiencing during grief. So it's not that they have to go through denial, anger, bargaining, depression, and acceptance. It's that you can start in somewhere like bargaining, being like, I will give everybody on this floor a trip to Disney World if I have my family, to going into denial of no, they're not dying, to jumping into anger, to finally accepting. Each person is different, so you just have to kind of deal with them in a different way. There we go. All of them. Okay, sorry. Okay, so some of the difficulties that you might come across is suspicion of euthanasia. So making sure that the family understands why you're giving the medications you give, that they don't assume that if you're giving them morphine, it's going to result in that. Decline in functionality. As the patient gets progressively worse, it's harder for them to do things. Family issues. Family issues can be extremely straining because when you get into family issues, one person may think that they don't want them to be a DNR, one person may want them to be a DNR, and that can end up being very difficult to talk with. Caregiver strains, it may be difficult on the caregiver to be handling the patient. So just kind of thinking about these different things that can be very difficult for them. You want them to understand the expectations versus reality of what's actually happening with the patient versus what do they think is going to happen with the patient. So when do you stop care? That's another thing that's difficult, is how long do we prolong it? Conservative care is rarely advocated. So a lot of times doctors can be very optimistic about where things are headed. It's kind of like, so something that's very difficult is the way we see things getting better is very differently than how the patient or family sees things getting better. For us, if a patient wiggles their toe, we're saying that's a huge improvement from yesterday. When you talk to a patient's family, they say, oh, they've improved. That means that they're going to go home. That means everything's going well. So you just kind of want to think about it and be realistic with your patient. So even after conservative care has been chosen, the disease still remains. So they're still dealing with all those difficulties that the disease comes with. So just kind of thinking about these things that can be very hard to manage while you're giving care to your patient. Like always, if you have any questions, please let me know.